from the News Channel 5 Network. This is OpenLine.
Hello, everyone. Welcome to OpenLine. Glad you're with us. Important topic tonight. We are talking about mental health. May is Mental Health Awareness Month. And so I want to, hopefully we can help people tonight. I want to talk about mental health and where things are as far as prevalence in our area and really all across the state and nation, and some programs that are underway here in Nashville. I have a great panel. We have with us Amanda Bracht with the Mental Health Cooperative. She's the Senior Vice President of Public Relations and Community Development. Thank you for being with us.
Thank you.
And Inspector David Imhof with the Office of Alternative Policing Strategies. Thank you for being with us once again. All right, the prevalence. Let's start with that. I'll start with you, Amanda. The prevalence of mental health issues right now, what are we seeing?
Well, what we've seen for a while is typically 1 in 4 individuals throughout their lifetime will have some form of diagnosable mental illness. But we've seen an uptick in diagnosable illnesses in the last couple of years, and it's largely, we believe, related to COVID. The isolation, the fear, the anxiety that a lot of people experienced, if that goes on for a prolonged period of time, can develop into mental illness where people need to seek help. They need to seek treatment.
So we are seeing more. So COVID is hopefully waning. The fact that you all are here, not on Zoom, that's a good sign.
Yes.
So is it getting better?
I don't think we've seen the trend getting better just yet. My hope is that now that things are opening up, we will be able to get people treatment quicker, and people will be more connected to things that give them resiliency, meaning they have better social connectedness, they are taking better care of their overall health, and long term we believe that will help in some of the symptoms that come out when you're isolated and you have prolonged periods of stress. The other thing that we're concerned about is the effect of our children. You know, children were out of school, children were not able to do the normal activities that a lot of, that kids do. And so we have seen an uptick in children's mental health issues as well. But again, it's my hope with advanced early diagnosis of some of these issues and really treating them on the front end, we will be able to start to see that leveling off and then decrease.
Do you think we're getting to a point where it's easier to talk about, or is it still not easy to talk about?
I think we're better than we were 10 years ago. I've been in the field for 20 years, and 20 years ago, you didn't talk about mental health. You didn't talk to your colleagues about, hey, you had a stressful event, how was your day? Now, I think that's becoming more common for us to check on each other. I think it's much more common for primary care physicians and pediatricians to ask questions about mental health, depression, anxiety. Again, 20 years ago, you didn't see those type of screenings being done when you went for a general physical, but now that's becoming common practice and best practices in the overall healthcare industry. It's my hope that 5 years down the road, we will talk about mental health just like we talk about a lot of health issues, whether that be diabetes, cardiovascular disease, that there's not this stigma related to your brain disorder. And that's the message we want to get out. Mental illness is not poor parenting. It's not that person's just bad. These are brain disorders. These are things that we know have changes in someone's brain and that we can treat.
And all right, David, I'm going to bring you in here. Sure. Let me ask one other question, though, and then I'm going to bring you in, because your program's fascinating, and we've talked a little bit about it in the past. But all right, let's say there's somebody out there watching, and they're concerned about a loved one. What would you tell them? I mean, what should they be looking for? What might they not know that you feel like they would benefit from knowing? They're concerned for a loved one.
I think the first thing is share that concern with the loved one. Often they will share it with a different loved one, but not the person they're really concerned about. Let's talk about it. Let's say directly, you're not yourself. You seem like you're depressed. You're not going to work. What's going on? And then there are resources out there. I mean, we've got the great partnership that we have with the police, but if we can get to it before it gets to that point where you're calling 911, that's what we prefer. So talk to your family physician. Talk to, there's resources in our city that you can call talk lines. There's several talk lines that we have in our city that are people answer 24 hours a day that are mental health clinicians. They can go through a series of questions with you and then help connect you to resources.
I love that. Yeah, just ask them.
Yeah, just ask.
That's a good start. All right, Inspector David Imhof, tell us about this program. You've been on before talking about it, but how is it going? It started back in
June 28th is when we launched.
So June 28th.
So we're coming close. We've gone through 3 quarters, or we're into our 4th quarter. So, I mean, kind of how it began was it started a while back when Mayor Cooper started the Policing Policy Commission. And he wanted the Policing Policy Commission, I think it was about 44 people. They also had subcommittees to deal with different policies like use of force, diversity, community outreach. And one of those topics was, how does, as a city and a police department, do we handle people that are experiencing behavioral health crisis or mental illness? And can we improve on that as a department? So they went over to the Behavioral Health and Wellness Advisory Council to get their opinion. And what that is a group of people that are leaders in the mental health field in Nashville trying to, from a different perspective, improve outcomes for people experiencing and have better resources. And what they recommended was a co-response program. So they sent that back over to the Policing Policy Commission. The Policing Policy Commission included that in their recommendations to Mayor Cooper. December of, I think, 20 is when Chief Drake was named the permanent chief. And in February of 21, I was called up to the headquarters and asked if because I'd been at the East Precinct for a long time, and I was asked if I would head up the Office of Alternative Policing Strategies, and I said, that's fantastic. What is that?
Yeah, it's a great name, but it's totally new, right? That's
and they explained there's some programs they wanted me to work on, but first and foremost, they wanted me to start diving into this co-response program. So for the first 4 weeks, I'm just sitting in my office reading about this. I'm calling different departments. And I knew that Mental Health Cooperative is our mobile crisis designee for the state, for the county of Davidson County. There's a designee in every single county in Tennessee. So logically, we knew our partner would be Mental Health Cooperative. So we made a call. I had lunch with Michael Randolph, who works at Mental Health Cooperative. We knew each other previously. And we started working out the framework just preliminarily. But we knew we were going to need more partners. So at that point, got a hold of Amanda, talked to Amanda about it, brought in the mayor's office. We started up a working group. This was around February of last year. And we realized this, and one of the reasons it's called Partners in Care is because it is a true collaboration. It isn't a police department program. It's not a mental health cooperative program. It's a citywide program. So mayor's office, ourself, Mental Health Cooperative, Public Health, EMS and Fire, Department of Emergency Communication, Hub Nashville, all these people came to the table. We met numerous times for months to try to figure out the framework. What's this going to look at? What's our goals? Who are we trying to reach? Who are we trying to help? And we came to that. The mayor's been really supportive of this. It's been funded. The pilot program has been fully funded. There's funding for expansion now. So after all that work, we were able to launch June 28th in 2 precincts. We started in Hermitage Precinct, and then we also started in North Precinct on our first and second shift. Currently, that runs from 6 in the morning to approximately 1:30 in the morning. So it's pretty good coverage.
Wow, 6 in the morning to 1:30. So most,
because we work 10-hour shifts now.
Yeah.
Previously, we worked 8.5-hour shifts. We're at 10-hour shifts, so that's where we're going to have some overlap too. So we used data to determine what precincts we should go to. So Hermitage and North is what we went with. And we had, I think we trained up 8 officers from each precinct. So we started with 16. Mental Health Cooperative assisted in giving our officers the crisis intervention training. So they've all had 40 hours of crisis intervention training before we started this program. And we also provided training for the clinicians that were going to be in the program. I think we started off with 6 clinicians and the 16 officers were volunteers to participate in this program, and I think we had 6 clinicians that volunteered to be in this program. So we knew the clinicians were going to enter into a new world, right?
Yeah.
This was a new atmosphere, a new culture.
Because they're going on police calls now. You say co-response. They're going out there.
They're in the car.
Yeah.
They're partners to a certain extent. They show up to roll call at the precinct every day. That's kind of their new work home. So we gave them training as well. We wanted them to understand some of our policies, procedures, why we do what we do, how to use a radio. We've issued them ballistic vests, the soft armor that they wear underneath their clothing. But we wanted them to be familiar with what we do as a department, why we do what we do. And we didn't want them to enter into it just not knowing anything. And then, like I said, they provided training for our officers, 40 hours. And there was lots of talks and discussions, and then we launched on June 28th.
And so what are the results? What have you seen in the time that it's been going since June 28th?
I think the results up to this point have been really positive. Again, it's a small sample size, it's a pilot. We're still working kinks out as we knew we would. That's why it's a pilot. But right now we knew not only would they be going to mental health calls for service, they could also be help on other types of calls for service. If they go to a domestic violence call, which might not be a mental health call on its face, but the officers have secured the scene. And would it be helpful and beneficial to have a therapist on the scene to help a victim of domestic violence who's undergone some trauma? We thought it would be. Or even if we go to a natural death of a loved one, and you have loved ones there that are upset, or even a tragic crash and people show up, would those be beneficial calls? So up to now, they've answered close to 3,000 calls total, and that's as of Monday. And of those calls, I think we've had close to 1,300 of those, or 1,200 of those have been specific crisis intervention calls.
And do you think people are not in jail that would have been in jail? Or even worse, someone hasn't been shot or tased or something that would have been otherwise? I mean, is that the kind of thing that
Sure,
should
we're
stop
tracking
because
all
of
that data. Mental Health Cooperative is tracking data. We're tracking data. The important note here is the Department of Public Health, who's one of our partners, we've hired 2 epidemiologists for this program that work through the Department of Public Health. They have data share agreements with Mental Health Cooperative, the Police Department, EMS and Fire, Department of Emergency Communications, so we can fully evaluate, are we making the goals, are we satisfying the goals we set for ourselves? And one of those goals was to divert people away from the criminal justice system and into the healthcare system. And as of Monday, I think 3.7% of all those calls for service that we've gone on has resulted in an arrest. And it's also important to note that we're tracking every single one of those arrests, and tracking not only what they were arrested for, what were the circumstances about it, we're reading everyone, but we also have a liaison in General Funk's office at the District Attorney's Office to find out what are the final dispositions of those, to find out, you know, are they being dismissed, are they being adjudicated, are they found guilty, are they just nollied, what are the circumstances, so when we can go back and continue training. We're training all this at our in-service right now. We've had roll call trainings on it. Lieutenant Brooks, who's heading up the program for us under the Office of Alternative Policing Strategies, he's teaching 2 classes a week for in-service just on this program. So we're trying to educate our officers. Right now, as of today, we have 77 officers that have received the crisis intervention training. Our goal is to have 500 trained, including supervisors.
Wow, really?
Because we think even though if you're not participating in the program, you can really benefit from the training. You know, because we understand that even if we go citywide, countywide, in every precinct, there'll still be circumstances that we're not going to have a team available. So would it be really good for us to at least have every officer trained in crisis intervention training?
And who is in charge when they go out to the scene? Are they both equal or probably not? How do you work out that kind of communication?
It's a collaboration. I mean, if it's something that deals with, you know, something about a violation of law or safety or security, obviously the officer is going to have more of a say in that. But if it comes to the care of the consumer that we're trying to care for and get them in the best situation possible, obviously we're going to defer to the clinician on the scene who's the expert.
And what are you hearing from the clinicians that go along?
Well, I was going to say one of the big surprises that we had was we anticipated a lot of the people we would be seeing would be people that were known to the mental health system. That is not true. So many of the people we're seeing, there's no previous history in the mental health system that we can find, and those are people who were going untreated. That was the #1 surprise. The clinicians were like, wow, we are definitely fulfilling a need that was going unmet. And had we not been on the scene, would this situation been identified more as a criminal action? Would it have just been, well, there's no action here, there's nothing we can do, and we'll leave the scene without them getting connected with resources? That was the first big surprise. The second big surprise was the level of acuity of some of the calls that they were seeing. People who were so severely ill that at the time the teams were involved, they needed to go to the hospital. And so we, again, did not anticipate that level of acuity when we first started the pilot.
And what happens when there is that need? Because I understand there's not enough beds in hospitals. I mean, what happens when acuity means they're in bad shape? Yeah,
for the most part, when we are saying someone needs to go to a psychiatric hospital in our state, that means that they are immediate danger to themselves or others, or they're so impaired by their mental illness that they're potentially posing a threat to themselves by not being able to care for their basic needs. So yeah, they're very sick. When we cannot quickly find a hospital bed, we are typically left with 2 options. One is to send them to an emergency room where they're waiting in a medical setting, hopefully getting some treatment while we're waiting on a psychiatric bed. The other option is our crisis treatment center that the Mental Health Cooperative operates, that we opened a few years ago. If we have the ability, we have them brought to that unit where it's contained. It's the officer and the clinician can get back on the street, but there's treatment individuals who are there at the crisis treatment center who can start engaging them, start rendering treatment while we look for the next placement.
And all right, one more question before we go to break. What, and this might not even be the right way to ask this question, but what is the #1 mental illness that you're finding? Like when you go out to a scene, is there one kind, like what, bipolar, or what would you say? How would you define it?
I would say that the top ones we're seeing are people who are profoundly depressed and they're contemplating suicide. They may have actually already made a suicide attempt. And then individuals who are experiencing some level of psychosis. Those are individuals who may have bipolar disorder with psychotic features, or people who are suffering from schizophrenia. There's also a fair number of people who are psychotic and we think it's due to drug intoxication. So that's something else that we can't definitively diagnose on the scene because we don't have the, the lab test to say, yes, this individual is acutely, they're on this drug and this is why we're having these acute symptoms, but that is our speculation based on various factors.
And before we go to break, drugs, huge problem.
Yes.
Still, right?
Yes.
Is that right?
Absolutely.
Yeah.
I mean, we're seeing overdoses. That's increased over the years, the opioid epidemic. And when you have that comorbidity of, suffering from some type of mental illness with use of drugs, it makes it even more difficult for them.
All right, that sets the table for our discussion. It's so important, and I hope, again, we can help some people tonight. So if you want to call in, question, comment, there's the number right there, 615-737+, 615-737-7587. We'll take a break. Be back right after this.